So I cannot believe that once again it is time for the Health Scholar Showcase. It's my favorite day of the year because I get to see so many people that are spread out and busy that I sometimes see on Zoom and sometimes talk to on the phone, but it's very rare that we're all together in person at the same event. So I'm very happy to see all of my colleagues and friends here today, so thank you for coming, first of all. Before we get started, I want to thank Abby Mott and Emily Valentine and the entire THRC team who puts this together, because I would absolutely be lying if I said I had very much at all to do with the wonderful experience that is the Health Scholar Showcase. In the original version, I was chief cook and bottle washer, but through our evolution, we have a team of people that do this event and make it really special every year, and I think you'll agree. It's special. It's different from most events. It feels different, and we've always tried to maintain that, dinner party, not academic conference kind of a feel, and that is because of the good work of Abby Mott, the director of Health Scholar Showcase, Emily Valentine, and all of the THRC team. So I want to say thank you. The second thing that I get to do is recognize a few people, and I don't know if you're here, but I want to recognize this is an event that we have tried to really protect as a faculty event. And the reason for that is not that we don't love students, but we know that when students are in the room, we want to focus on students. And there are very few times when we take a moment to have a conversation among colleagues about research. And that conversation can sometimes be a little bit different when it's among colleagues and not with students, because of just, our levels of expertise and interest and our responsibilities. And so, that said, we do recognize a lot of student scholars here. And those students come along with the faculty that we have the privilege of working with at the Health Scholar Showcase and Translational Health Research Center. So first I wanted to ask, are there any students, undergrad or graduate students here? Woo! All right. Are co-authors on papers, and they work in labs, and they do really, really good work to advance our research mission. And so today I just wanted to recognize them, because I know you're here with mentors who do a great job with you because you're here. So thank you. Spending your Friday afternoon on a research event, that's good. That's good. And then the second thing I wanted to say was, do we have any members of the community, and I'll say that broadly, who are not with Texas State that are here with us today? Okay, yay. This year, one of the big things that we've been doing at the Translational Health Research Center was developing our ECHO platform and our ECHO Hub. And this is a virtual learning network. And one of the programs that we've been running is the Mental Health Community Collaborative. And these meetings are virtual, and they involve people, usually around 40 to 70 people every time. And that is the work of a team that includes Shelby Sneed, Cody Gold, and who else? Marsha and Lauren Lee, and Marsha Burry. So that team has been working very closely along with our community members, because we are in the business of translation, meaning we want to make sure that the research that we do gets into the hands of the people who can benefit from it. And that doesn't just happen by accident. We have to have that pipeline, we have to have those relationships, to have those conversations, to make sure that the work that we're doing is answering the questions that need to be answered in ways that have real application in the world outside of our campus and our academic world. And that is not to say we don't do great academic research, because we do. But we do it in a way that includes, baked into the plan, how are we going to be sure that people outside of our academic world can see, hear, know, and benefit from the work we do here at Texas State. So I want to really thank our community partners for coming today. And last but not least, I want to introduce our Chief Research Officer, Dr. Shreek Mandayam. I think many of you know him. He is going to be introducing our keynote today. So thank you all so much for coming, and I look forward to the talk and to seeing you afterward at the reception.
also on me to project like she did and not use a microphone either. Good afternoon. I'm Shreek, Mandayam, the VP Research here at Texas State. So, before I get to our distinguished keynote speaker, I thought I will do a little bit of a history lesson out here, not to bore you too much. So I want to really start 17,000 years ago, because the reason for that is here in San Marcos, at the headwaters of the San Marcos River, Spring Lake, human beings have lived here for almost 17,000 years. So this is one of the most amazing places that you have in North America with the longest record of human civilization, and that's really where Texas State University was founded 125 years ago, right here. I'm going to fast forward a little bit to the mid-60s, 1965, where the Higher Education Act was signed by Lyndon Johnson, our alum at Texas State, also an employee at Texas State, President of the United States, that made education accessible to all, an amazing, remarkable time in America at the height of the Civil Rights era, where just the possibilities were endless. And here in San Marcos is where the act was signed. Going forward in time a little bit, let's go to 2023, where the Texas legislature, in the state of Texas, made Texas University one of the 4 universities to be recipients of the Texas University Fund, a $4 billion fund to benefit Texas State with an endowment to support research. And we got our first, I think in 2024 we got about $22.5 million from that fund, and this year we got about $30 million from the fund, and we are eligible to get over $70 million next year. The legislature is in session. I don't want to jinx it too much, but I think we have broad support that Texas State's research has grown remarkably to merit that. We are at about $165 million in research funding, which is a testament to all of you gathered here. So again, my history lesson is not like a linear timeline, so I'm going to go back 8 years now, because that's when our Melinda Villagran was able to persuade the then President Trout to get support to start this absolutely wonderful Health Scholar Showcase. So this is the 9th Health Scholar Showcase. We are going to be approaching a decade here with Melinda's leadership. And, so our university level research centers are all stars, right? They're fantastic. But the Translational Health Research Center, it's a constellation by itself. Because what Dr. Melinda Villagran has been able to do is secure external funding and recruit faculty stars from across the university and support them and grow them and nurture them and mentor them so that they become successful scholars and researchers and educators and contribute to the science, contribute to the economy, contribute to the education. So it's truly remarkable what Melinda has been able to achieve here at Texas State, long before I even got here, so I just tried to get out of her way mostly. I just want to acknowledge Melinda first as the founder of something remarkable here at Texas State that will endure for a very long time. This 9th year of this conference, the theme is Bridging the Divide, which is really a focus on mental health and mental health care. So there are many faculty who work in this area at Texas State. I'm just going to call out a few of them. Dr. Ty Shepis, mental health and substance abuse, Dr. Kelly Clary and her colleagues on healthcare among veterans and caregivers, and Dr. Vangelis Metsis, who uses machine learning, data mining, and computer vision to identify new ways to provide accessible mental health care to technology. So pretty remarkable stuff going on here. The state has recognized the work that Texas universities are doing. There is a proposal to create a brand new funding mechanism called DPRIT, which stands for Dementia Prevention Research Institute of Texas. Thank you, I got it. Very much like secret, and I think we at Texas State, and especially the THRC, led by THRC, would be very eligible to receive the first grants to that center. So we are definitely going to compete the hell out of this with the other universities. There's one about 20 miles up north, I forget its name. We give them a run for their money, so that's what we can do. So now it's my pleasure really to welcome and introduce our very distinguished keynote speaker, Dr. Daniel Knoepflmacher, who is an MD and MFA. When I read this first, I was like Lydia and my assistant, like, Lydia, you really need to proofread things you give me because there are no such MD MFAs out there. But then, after graduating magna cum laude from Columbia University with a major in religion, he pursued an MFA in film production, which I'm sure San Marcos is going to be the hub of very soon because we're going to get the world's largest film studio right up the road here at the University of Southern California. So he had a successful career in the entertainment industry, then attended medical school at Oregon Health and Science, honored as a top student in psychiatry, and got inducted into the Gold Humanism Honor Society, did his residency and served as the chief resident at NewYork-Presbyterian Weill Cornell Medical Center, where he currently serves on the faculty. So he serves as the director of the General Psychiatry Residency Program and the vice chair for education in the Department of Psychiatry at Weill. And his podcast, On the Mind, explores key topics in psychiatry, psychotherapy, mental health research, and many such areas. So very apropos for our theme of our Translational Health Sciences Research Symposium this year. So it's my great honor and pleasure to welcome Dr. Knoepflmacher to the stage.
Well, thank you. I have to say, I was really surprised when I first received this invite and went immediately online and looked at Texas State and just was blown away. And now I just feel such a tremendous honor to be here. And I have to say, what I saw virtually is nothing compared to the reality of being here and being in this part of Texas. I got to see a little bit of hill country last night, and then especially just walking through the hall. I only got through one floor, but even there, just seeing the amazing passion and creativity and energy that is going on here at the work that all of you are doing, it's really, really impressive. So as I said, when I first got an email about doing this, I thought to myself, ooh, I don't want to hit the mic. I'm a psychiatrist, and I'm not really doing research. Did they send this to the wrong guy? So then I was able to get on the Zoom with Melinda, and I learned that this came about because of the work I do on a podcast, which as Shreek said, is called On the Mind. And there I cover topics related to mental health, and I speak with guests who are expert clinicians or researchers. And I always begin the podcast the same way. I ask each guest to tell their story, the narrative of how they came to be the person they are today, working in psychiatry or psychology or research science. And each of them then shares their personal story, which humanizes the scientific or clinical topic that they're speaking about. And I did this selfishly because I found that it connects me with the person that I'm speaking to, but also because I thought it would really connect them and make them accessible for the audience that's listening. So I figured I'd do the same for all of you today. And Shreek, you actually got to some of the points here, but I'll tell you the story of how I became a psychiatrist, which is a very zigzaggy story. I was the guy in high school who loved listening to the angst of all of my peers and would sit and talk about teen problems all of the time, and went to college thinking I was going to be pre-med and doing that to become a psychiatrist. And I got there, I went right into general chemistry, and within about 5 weeks said, to hell with that, and dropped it. And then I took this deep dive into the humanities. I went through all these different majors and finally landed on religion. It was great studying these religious traditions from around the world and learning about the common human themes that transcend culture. And at the time, this was the time, I'm dating myself, but of the big kind of independent film burgeoning, like Tarantino was sort of coming out at that point. And somehow, even though I was a religion major, I figured, you know what, I want to go and become a filmmaker. And so after graduating, I moved to Los Angeles. I went to USC, got a graduate film degree, and then said, oh my God, I got to pay off all these loans. So I jumped right into working in the film industry and found by chance this niche of film editing. And specifically, I was creating the movie trailers and the television spots for major Hollywood studio films. And that my actual specialization, it was comedy, kind of dumb comedies. I don't want to be pejorative, but comedies. And you may have seen some of my work. I mean, things like Big Mama's House 2 and other classics. And, you know, it was a steady living. But the truth is it took a major toll on both my physical and my mental health. I was racked by anxiety. Believe it or not, the stakes in that world are very high. If you don't get that Big Mama's House spot done quick enough, you're in big trouble. I was 25 pounds heavier than I am today. I developed back pain for the first time in my life, reflux, migraines. My mind and body were telling me this wasn't the right career for me. And then my first daughter was born. And that has a way of changing your perspective. And a light bulb went off in my head. And I said, why not return to my teenage dream of becoming a psychiatrist? So I went back, I tried some of those pre-med courses, and lo and behold, I was attacking them with this passion and excitement and focus that I never could have had in my first year of college. And I then decided to apply to medical school, and I sat down to write the personal statement in my application. I said, oh my God, how do I explain all this meandering that I just described to you? What ties these different things together? And that's when it came to me. Religion, film, psychiatry, they're all centered on the commonality of human narrative. I've always been drawn to the meaningful connections that come through stories. And this type of human connection through narrative is actually fundamental to what I'm going to be talking to you about today. Stories spark meaningful moments of empathy and understanding that are at the foundation of effective mental health care. And they are very central to this topic, which is how we can bridge the divide to make mental health care more accessible. I'll be using bridges as an analogy for effective mental health care because just as bridges are physical structures that allow us to cross over divides and get to the other side, our system of mental health care should ideally be a supportive structure for people who are journeying from illness and suffering to recovery and resilience. Unfortunately, though, our mental health care system is in some need of major repair. While we have an overarching system in place, it's got some structural issues. And it means that not enough people are getting the help they need. In fact, a national survey from 2021 by SAMHSA, which is the Substance Use and Mental Health Services Administration, showed that 20% of Americans reported they had a mental health condition in the past year. Unfortunately, more than 2/3 of them did not receive treatment. So doing some mental math, a rough estimate based on the US population, that means that over 45 million Americans didn't get the care they need. Many use the word crisis when they talk about mental health in this country, and that includes the CDC. You can see a quote up there from them, and this is especially when it comes to our youth. Similar to that SAMHSA data I just showed you, the CDC did a national survey, and it showed 1 in 5 American adults experience symptoms of anxiety and depression. That was in 2023. We've also seen an increase in what are called deaths of despair, deaths from substance use, alcohol use, suicide. These have more than doubled over the past 2 decades. The figures for children and adolescents are stark. 40% of high school students reported persistent sadness or hopelessness in 2023. Severe depression affects more than 1 in 10 of adolescents. And certainly this was all worsened by the pandemic, but the fact is this trend was happening before COVID-19 hit. And more disturbing, most disturbing of all, is the increase in suicide rates, which increased by 57% from 2007 to 2016, and it's now the second leading cause of death among 10 to 24-year-olds. It's even worse among Black youth in America, where the suicide rate is rising even faster for the Black youth than it is for the equivalent same-aged white youth. And in a really startling statistic, it's at the point now where it's double that for those under age 13. This is a major public health problem, especially when you consider, thinking about young people, that 3/4 of all psychiatric disorders emerge by the time people reach their early 20s. And it gets back to a problem with access, because the mean lag time between experiencing symptoms and getting treatment is several years. Over 3 years for depression and anxiety, more than double that for people with bipolar disorder, and it goes on with other similar kind of lag times for diagnoses like obsessive compulsive disorder. The best hope we have of reducing future mental illness in adulthood is for children and adolescents with psychiatric diagnoses to get rapid and effective treatment right away in adolescence. I also want to call your attention to an advisory that was released in 2023 by the US Surgeon General Vivek Murthy. He identified an epidemic of loneliness and social isolation among Americans, with approximately half of adults in this country reporting loneliness. I'll define these 2 terms for you. So social isolation is the objective state of having few social relationships and infrequent social connections. Loneliness is that subjective feeling that comes as distress when people feel like they're isolated or disconnected from others. The Surgeon General deemed the levels of social isolation and loneliness to be a significant public health issue because they're shortening people's lifespans. In fact, they compared it an equivalent risk to smoking 15 cigarettes a day. And it also leads to increases in many of the major medical diseases. Like mental health problems, as I've just been describing, this trend is increasing. In fact, it's been increasing consistently since the 1970s. I listed some of the proposed reasons why this trend is happening. I'm not going to elaborate on them now, but I'm going to re-emphasize the concept of social connection, or in this case, the lack of it. All of this is directly related to mental health because social isolation puts people at higher risk for mental health issues. And conversely, mental health issues will result in social isolation, social withdrawal. So there's this direct connection between the two. So that's the scope of the problem. I've given you a sense of the scale of it in this country. But the other issue, and really the main issue I'm here to talk about, is the problems we have with access to care. So I'm going to tell you why. I'm going to go through some of the reasons why people are not accessing the care they need. This is a cartoon from the New Yorker, and in case it's too far back for people to read, there's a doctor speaking to a patient, and the doctor says, "This is most likely caused by the stress of having your symptoms constantly dismissed, but I wouldn't worry about it." There's truth in humor. I think this comic reflects the experiences of many who seek help in our healthcare system, and that's especially true when coming in for treatment of mental health conditions. People often feel dismissed, minimized, judged, even deficient and ashamed, which is the corrosive effect of stigma. Now, stigma has multiple forms, starting at the individual level and going all the way out to society at large. And looking at this cycle of stigma, starting on the top left, is societal stigma. The stereotypes that come from misunderstanding, misinformation, which is common, especially with mental health issues, and people see this as prejudice in media, politics, culture. Self-stigma is the internalization of these negative stereotypes, and this often results in decreased self-esteem and decreased self-efficacy. The effects of this on all levels, including the levels of families, communities, the healthcare system, it often keeps people from seeking appropriate care, and even when they're getting it, sticking with it. It makes sense, though, doesn't it, that people don't want to lean into something that comes with so much shame and feelings of deficiency. The truth is, it's so pervasive that clinicians, and this includes psychiatrists, are part of the stigma cycle. My colleague on the top there, John Avery, is an addiction psychiatrist, and he's done work researching stigma towards substance use disorders in healthcare. He did a study showing that stigmatizing attitudes actually worsened with training among psychiatry residents. It means they came out of medical school bright-eyed, idealistic, wanting to really help, and then they go through residency and they got worn down and developed this negative bias towards people who were struggling with substance use disorders. Actually, I'll get to, I'll tell you why I think this is the case. Because I believe these residents had a biased sample. They were seeing the most acutely severe cases, and they weren't very often witnessing the many successful stories of recovery that come with all of the effective treatments we have for substance use disorders. So Dr. Jody Pathak, who you see on the right there, is a health services researcher, and he used machine learning to analyze large data sets from medical records, finding that clinicians were using stigmatizing language. They were using in their notes words like junkie, describing someone who was using heroin, or a drunk when describing someone who had a problem with alcohol. This was documented, and I think it shows how powerful language is, because it shapes the thinking and behavior and undoubtedly colored the interactions that these clinicians had with their patients. And this becomes all the more important because there's been laws passed in the past few years that have made our medical notes open to patients, which is, I think, a good thing. But can you imagine reading a note with that kind of language describing you? Another major factor impacting mental health in general is really a big factor in how much people can access care are the social determinants of mental health. And humbly, I'll say, while the healthcare system plays an important part in maintaining people's health, it's really only a tiny slice of the bigger pie, about 10%. Because thankfully, most of us don't spend our lives sitting in doctors' offices, therapists' offices, or the hospital all the time. Really, from early development through old age, our mental and physical health is determined by the conditions where we're born, we grow, live, work, and age. When there are major problems in these areas, they of course impact mental health through innate stress response, and that in turn affects the psychology and physiology, which inevitably leads to illness. A lot of public health research shows direct correlations between mental health outcomes and social factors like economic status, social power, access to healthcare, healthy food, stable housing, safe neighborhoods, early childhood support. There's a lot of increased risk for medical and mental illness in children who have adverse childhood experiences, or ACEs as they're called. This includes traumas like physical, emotional, sexual abuse, neglect, parental strife, parental substance use or mental illness, family member incarceration, domestic violence. All of this, of course, correlates with socioeconomic stressors. And then youth with 4 or more of these categories of adverse childhood experiences are at a fourfold risk for increase, fourfold to 12-fold, I don't even have that many fingers, increase of substance use, depression, and suicidal behavior. And this directly relates to access, because again, these communities that are hard hit, whether it's in rural areas or inner cities, they're often the least connected to care. I touched on a mental health disparity earlier when I was talking about the differential in suicide among Black youth versus white youth. And this is something that is important to address here. This is a bar graph from a paper using data from Kaiser Family Foundation survey looking at health disparities. And all those in this survey reported fair or poor mental health. And the bar graphs there represent the percentage of groups that said they received mental health care. You can see the disparities between the groups, and I expect you'd see something similar if we were sorting by wealth. And it's important to think, when you think about health disparities, about the multiple layers of stigma, the intersections that occur for some in our society who might, even within their own communities, certainly within their own communities, face mental health stigma, and then turn to the healthcare system and find misunderstanding culturally and rejection there. The last 2 bars are really important to highlight. They show a major discrepancy between those who are insured and those who are uninsured. And indeed, the cost of care is a major barrier to access. It's cited by more than half of adults with mental illness as the biggest barrier to care. This is true, of course, for those who are uninsured, which we saw in the prior slide. But even having insurance isn't enough, often, to pay for mental health care. One big contributing factor to this problem comes from a lack of parity between mental health care insurance coverage and physical health care insurance coverage. There's a major disparity between the two, and it's an access issue, which has been big enough that it's actually gotten the attention of the federal government, the state governments, and many others. And I'm going to go through a very quick and dirty history of what has been happening with fights for mental health insurance parity. Back in 2008, Congress passed the Mental Health Parity and Addiction Equity Act to ensure equal coverage of treatment for mental illness and addiction equal to treatment for medical care. Additional laws then needed to be passed to implement it, and those were set in 2013. And yet, even though the letter of the law was out there, insurance companies found many ways to skirt the law, and I think you're probably in life familiar with some of those ways. Denials of coverage, onerous pre-authorizations, all of these things that made it very difficult to get the mental health care paid for. This led to a class action suit against the biggest insurer in the United States, United Behavioral Healthcare, in 2019, and a federal judge ruled in favor of the plaintiffs who were suing UBH, noting that the way that they had set up their coverage policies prevented parity for patients seeking mental health care. UBH then appealed, and it's gone back to the courts, and it's not settled, and the prior practices continued. Then, in late 2024, a new rule was implemented by the Department of Health and Human Services and other government agencies designed to, through executive action actually, require insurers to follow rules for treatment coverage that comply with the Mental Health Parity and Equity Act. Then, in January of this year, a lawsuit by a trade group for employers sought to void this new federal enforcement. And they were representing employee insurance, which covers about an estimated 175 million Americans. And that case is still in process now. So you see how this back and forth occurred. I imagine it will continue, but as it does, the status quo of disparity between mental health and physical health insurance coverage persists. With a show of hands, I want to see how many people in this audience have ever heard about or experienced themselves problems trying to schedule an appointment with an available mental health professional. Okay, all right, well, I think this indicates part of what I'm going to get to here, which is that we have a major shortage of providers. In 2023, the Bureau of Health Workforce, which is part of the federal government, issued a brief, and they described this also as a mental health crisis because of unmet behavioral health needs among people of all ages. They described how more than half of the US population lives in mental health professional shortage areas. And some regions are especially hard hit, rural counties being the most likely to lack behavioral health care providers. This table that I have here is taken from that brief, and it displays on the left the status quo, where we are right now. It also then estimates on the latter two columns what it's going to look like in the year 2036. Now, looking at the current numbers, you can see there are significant deficits in most areas, and the worst unmet need is actually in the number of psychiatrists. The second column describes unmet need in the future with population growth, because just that alone will increase the demand. Elevated need, which is that last column, is actually what I would describe as being the victim of your own success, because that is estimating if we start doing a better job of getting more people access to care in other ways, we're going to be even more underwater in terms of the demand of treatment versus the supply of treatment providers. So I've painted a picture of how the bridge is broken in multiple ways, and I want to turn to how to fix it. This is a picture of a bridge that I think you're probably all more familiar with than me. I particularly like it because of the line of people that are silhouetted on the top against the sunset. And I think it's important because it captures a moment of social connection. I guess in this place, in this time and place, they were waiting for some bats. As I've said, though, connecting people is a foundational requirement for mental health. And don't just take, I've got to stop hitting my chest, I'm so excited here. But don't just take my word for it. Listen to the Surgeon General. I don't know if you noticed this when I showed this slide earlier, but the subtitle there says, "The Healing Effects of Social Connection and Community." I talked about stories in the beginning, the meaningful social connections that come from them. That is something which is the focus of a field called narrative medicine. Dr. Rita Sharon from Columbia University in New York, she wrote a pioneering article about this in the Journal of the American Medical Association. And in it, she emphasized how the ability to acknowledge and understand others' stories is central to the practice of medicine. It's something that all doctors should have as a core competency. I guess this had to be stated because I don't think all doctors necessarily do have that as a core competency, as we spoke about earlier. But her work helped spawn narrative medicine programs that have been adopted across the country. In 2020, the British Medical Journal, or BMJ, published a systematic review of these programs and their efficacy, and found they were effective in improving skills of relationship building, empathy, resilience, and they help to prevent burnout. This approach improves the experience for both doctors and patients. An example that was adopted in the VA system, which I have the titles for on the right, they initiated a program called My Life, My Story. It was for veterans to tell their stories and then keep those stories in the medical record so that all of their care providers could see them. Almost all the medical staff that they surveyed said this helped their treatment. It allowed them to make more personalized decisions about the medical care they provided. And of course, it benefited patients. At one cancer treatment site in the VA where they adopted My Life, My Story, the patient feedback scores showed a significant improvement once it was implemented. So think about the good doctors that you've had in your life, and I bet you they were people who listened to you and really conveyed that they understood what you were saying. The fact is, we're social animals, evolutionarily hardwired to connect with each other. And part of the actual neuronal hardwiring for social connection was in part established in 1992 with the discovery of mirror neurons in premotor areas of the brain in monkeys. And they found specific neurons that fired when the monkey did an action like grab a banana, and I know banana, it's a monkey cliche, but that's what came to mind. But also when the monkey watched someone else grab a banana. With more research in humans over the ensuing decades, we've learned more about how these neurons and related brain circuits are involved in social learning and how crucial it is for human development of cognition, language, motor action, and of course, empathy. Babies are hardwired for this kind of social learning. Early on, they begin mimicking the movements and expressions they see. There have been very sad studies, actually, showing how isolation from early nurturing without human connections has profound effects on the brains of growing children. And there was these studies from Romania that showed orphans who were neglected grew to develop more psychiatric diagnoses. They exhibited severe social communication deficits, lower educational achievement when compared to those who didn't have the similar course. As children develop, they understand what is going on in other people's minds, which builds the capability for empathy. And then returning to the healthcare arena, we have some studies that show how patients actually experience less pain with a supportive, empathic clinician present. And then furthermore, they've even linked this to correlates in the brain. One fMRI study examining the brain activity of both the patient and the supportive clinician showed concordance in activation in the dorsolateral prefrontal cortex in both of their brains, which directly correlated with empathy felt by the clinician and the subjective decrease in pain experienced by the patient. In psychiatry and psychology, we call this healing relationship a therapeutic alliance. And it's essential to successful psychotherapy. It's a relationship built on trust, empathy, mutual respect. It provides the basis for personal growth and guiding people through sometimes difficult therapeutic change. A systematic review showed that it's the engine for most positive therapeutic outcomes in treatment. And that's regardless of what psychotherapy modality is being used. So we know that these things need to be in place for good mental health care, but what about those other problems that I identified? We need to find more providers to provide this empathic care. What are some ways we can address the workforce shortage in mental health? Well, to start, we have to train more people to do this work, and I'll use psychiatry as one example among the many types of mental health care providers. We have seen growth in popularity of psychiatry as a specialty choice for medical students, which is great, but even more importantly, there's been a growth in the available spots for training future psychiatrists. Some of this comes from increased congressional funding, and obviously funding is the big piece here because we're not going to create more spots without funding. And you can see in that bar graph on the left from some of the other sources that have offered this funding. There are similar measures for other type of mental health clinicians. States have provided incentives for people to pursue these careers. They've taken steps to reduce administrative red tape and to increase salaries. Unfortunately, though, even with this level of growth, as that table that we looked at earlier showed, we still might not be able to meet the demand, especially for psychiatrists. And one effective way of addressing this is through a model called integrated behavioral health, which includes probably the most popular example of this, collaborative care. And that's a model where a psychiatrist and a psychologist lead a team, a larger group of care managers and therapists. The patient is seen primarily by the care manager, who assesses them and maintains contact with them. And then after that assessment, they may make a referral to a therapist on the team, or if they feel that they might need a medication, they will then send them to their primary care divider, who they're linked with, who then will prescribe that medication. The psychiatrist and the psychologist supervise all of this care with the managers. They go over the treatment plans. The psychiatrist also works directly with the primary care divider, advising them on the medication prescriptions. And then the care manager continues to be the direct point of contact through the treatment course. With this model, where the psychiatrist provides supervision and consultation to other providers, they actually have the capability to be taking care of a much larger population of patients than they'd ever be able to do if they were the sole provider directly managing each patient's care. And this model has been adopted across the country, and research has shown that it increases access to care, it improves behavioral health outcomes, it enhances provider and patient satisfaction, and importantly, it's reduced healthcare system costs. Another important way for us to extend care, and I saw this today in some of the posters that I witnessed, is technology. Virtual care or telemental health, it's made it easier for many to get care. It's increased access for people in rural areas, allows them to be seen more rapidly and conveniently. And then also, smartphones have led to the adoption of many apps that can help with the treatment of mental illness. Another thing that I saw looking at posters today. It offers, for instance, easy access to mindfulness exercises, let's say evidence-based cognitive behavioral therapy, apps, lots of other digital mental health interventions. Now, I want to state these are not replacements for human clinicians. I'm not just trying to protect my job. They can extend the care that's provided by the mental health workforce and then provide interventions also during periods of waiting for treatment between sessions. They also have been used really helpfully to streamline clinical processes so that clinicians can see patients more efficiently. I'm going to take a slight detour here, though, because I feel the need to talk about technology. I could have just made the whole talk about that, but it's a big enough topic on its own, and the main message I want to convey to you is it's a double-edged sword. It has the power to connect socially isolated people, but it also can exacerbate disconnection because it replaces in-person interaction so much of the time. And in the case of social media, if you talk to teens, often it can make them feel more lonely rather than less. It's a great source of useful information, and often is a great place for people to learn about mental health conditions in a destigmatizing way. Yet it's also full of detrimental misinformation. So we need to always balance the ways it can help with the risk of harm whenever we think about it. I have here a still from a video similar to many that are out there. I don't know if this is TikTok. It spreads misinformation about ADHD. I can tell you that these are not direct criteria taken from the DSM-5. And online communities out there are great in so many ways because they provide support and they can help destigmatize certain conditions, but they also, if not in the right hands, can lead people astray, and things like this really propagate misconceptions in popular culture. And sadly, this risk extends to some of the mental health services that you may have been seeing advertised so heavily. There was a class action suit against Talkspace, which provides digitally delivered therapy, for sharing user data with TikTok. Many complaints have been filed against BetterHelp, another major player in that industry, especially because they are not having adequate vetting and quality control of the therapists they hire. I don't know if that's related to some of the comments right there. Some services offer therapy through text, and that raises questions. These are built by companies who have an economic model that they have to please their shareholders. At what point might they just say, you know what, forget the human therapist, let's just use AI, it's all through text anyway. And I'm not here to speak against any of these companies, and I'm not here to endorse them, but certainly providing more care to more people is what we need. There needs to be, however, stricter regulation of these services to protect people and ensure that they're getting high quality, evidence-based, and confidential care. So to sum that all up, my little detour, technology is a powerful tool. It comes with significant risks. It can be an important way to increase access, but it needs to be regulated. All right, back to the other topics. I talked about mental health parity, and I said we have a long way to go, but I do want to provide some hope in saying that there's lots of organizations out there coming together to advocate it, inform the public and the government about these issues. Both APAs, that's the American Psychological Association and the American Psychiatric Association, are united in trying to fight for this, and they tend to argue about almost everything else, so it shows how unifying it is. That firm on the top right, PsychAppeal, is a law firm that was started by the lawyer who won that landmark case that I mentioned against UBH. And he continues to do lots of fights, even at the legislature level and in the courtrooms, to move this forward. So all of these people will be continuing this fight. Stay tuned, pay attention to it in the press as it comes up, and we'll see if we can make any progress on parity. Turning back to mental health disparities, we have to actually, I think about all of you, where we really need to be researching population health. It's crucial. This study here showed how mental health and brain development is directly linked to low income. So lower income was associated with smaller hippocampal volume in the brain. But interestingly, in states where there were more comprehensive programs of public support, these disparities in hippocampal volume were reduced by 34%. So you're seeing a direct biological effect of social programs. By the way, the same correlation held true for the relative prevalence of mental health problems between these different states. So just to quickly think about some of the ways to address mental health disparities. Again, this is not in the mental health care system. This is out in the community. We need to have research like I just cited and use that science to really advocate for direct benefits of public initiatives, drive some meaningful policy change. And I know right now that might not be the most winning battle, but we have to keep doing it, and eventually maybe we can convince the powers that be that this is worth it. Community partnerships, building partnerships between health systems and community-based organizations. There's a lot of work going on with this. It's really important to collaborate with people in the community, schools, faith-based organizations, community centers. They know the culture and the needs of the people better than the people in the health systems. So there needs to be more connections there in partnership. Providing culturally and linguistically appropriate interventions. Programs that do this, that are tailored to the diverse populations that are served in healthcare systems, it really improves engagement and outcomes, and it addresses those specific cultural needs that often, when they're not addressed, are reducing communication and not, and basically keeping people from accessing care. And lastly, basic community resources that fill up the rest of that pie of determinants of health that I talked about. That would be fresh food markets, social activities in public parks, free or low-cost cultural events, exercise, nutrition class, free support groups, early childhood education for parents. These are really important to improving these outcomes, and they're often overlooked. So this is just an incomplete list, but it gives a sense of some of the community-based interventions that can positively impact social determinants of mental health. And I want to turn to stigma, which I talked about earlier. Destigmatization starts with each one of us. How can we fight the stigma we feel about our own struggles with mental health, and then also be there to support those who are suffering from their own mental illness? This slide shows 3 strategies. This was designed for parents to use when supporting their children. And I think it applies to any of us as we're out there helping others through tough times. Don't be afraid to go deeper when someone doesn't look fine, but just says, I'm fine. Share your own struggles, and that can be a way to break down some of the barriers of internalized stigma that others might feel. And once again, this is about building the bridge on the individual level, establishing human connection, trust, openness, empathy, the same building blocks that are so crucial to the therapeutic alliance. Destigmatization also needs to occur at a societal level. And one good place for doing that is in popular culture. There's a long history of stigmatizing portrayals of mental illness in films and television, and we can really change that. I have 2 examples here. Inside Out really humanized the complex emotions and struggles that adolescents experience. And also, certain celebrities can talk in vulnerable ways about their struggle and resilience, which can really help others, especially in our celebrity-obsessed culture. The National Alliance on Mental Illness, or NAMI, which I was on one of my earlier slides too, they're a really important advocacy organization that focuses on mental health. And they organize lots of efforts at destigmatization by partnering with celebrities to share their own stories and providing guidelines for reducing stigma in workplaces and other settings. And we need to continue to do work destigmatizing mental illness in the healthcare environment. I mentioned my colleague John Avery earlier, whose research had identified that growth in stigma among psychiatry residents as they trained. So building off that research, he set out to find a way to address it, and I had the pleasure to collaborate with him on this project. What do you think was the core element of this destigmatization curriculum that we made for residents? It was adopted nationally across the country. It was a documentary we created featuring interviews with people who recovered from substance use disorders. They demonstrated the resilience and hope that allowed them to overcome addiction, and they also shared painful stories of feeling judged and misunderstood by healthcare providers when they were using. John then studied the impact of this curriculum and demonstrated that residents' attitudes towards individuals with substance use disorders improved significantly. Another person I mentioned earlier, Dr. Jyoti Pathak, he is looking into following up his research, which showed all this stigmatizing language in medical notes, and then here again using technology in a positive way, seeing how you can use language models to find these things in medical records as people are entering them, and then cueing them and saying, hey, a more appropriate term for this would be X, so that they have real-time cueing to not use such stigmatizing language. So we've discussed the importance of stories, using meaningful connections to counteract social isolation and loneliness, and the therapeutic alliance that drives recovery in mental health care. I shared some of the ways that we can repair the broken bridge and increase access to mental health care. And I want to end by encouraging all of you to spread the word. This can be done on an individual level by helping others directly, or collectively in your community or your professional organizations. Frankly, it's what I'm doing right now, standing before you today. I'm trying to get the message out. If we actually build solutions and no one knows about them, what kind of progress is that? So I'll give you an example. Right here, this is the 988 Suicide and Crisis Hotline. How many people in this audience have heard of 988? This is a good crowd, so I'd say like 50%, which is great. When this was launched in 2022, by 2024, they tried to get a sense of how many people knew about it. 20% of Americans knew about it. That means 80% of people had no idea that this existed. Now, for those of you who hadn't heard about this before, maybe that's just a small fraction of increasing public knowledge about this. And maybe one of you will encounter someone who's suicidal and share this resource. There's the possibility that just us discussing this right now might even help one life to be saved. This is the power of spreading the word. All of us can play a role in this. It shouldn't just all fall on our shoulders, of course. The government, the healthcare organizations, advocacy groups, they all need to be doing the work too, but we can help. It's a big part of why I started a podcast, to inform the public about mental health in what I hope was an accessible way, and to give a platform to clinicians and researchers to share their knowledge and educate the public. Some of the people I mentioned to you today, in fact, John Avery and Jyoti Pathak, they both came on the podcast and spoke about their work. This is actually, I think, where all of you come in, or many of you, because I know we have people doing different things here, but those of you doing translational health research, this really comes into play. Like those of you who presented your posters in today's showcase. Tell the story of your work. Communicate, inform, educate, and most importantly, there's one thing I keep banging the drum on, is connect on a human level. Because in this time of disconnection, of polarization and misinformation, we all need to work extra hard to listen to each other and make sure we tell a clear, compelling, and understandable story of why science and medical evidence matters. Thank you all for listening.
So I think we have a little bit of time for maybe 1 or 2 questions. So, yeah. You can have a
Actually,
floor.
yeah.
Anybody want to ask a question? Dr. Knoepflmacher? Dr. Rhodey.
So this question's going to date me a little bit, but so when I started college in 1985, I got a typewriter for high school graduation, right? So I've been on the divide of the internet, email, and social media explosion. Maybe a controversial question for you, but what's your thoughts on social media and the use by all ages and how that's monitored?
It is really controversial. And yeah, no, I mean, I'm on LinkedIn. It's a form of social media. And there is, have people heard of Jonathan Haidt? I forget the name of his book, but he's at NYU, and he wrote this book about the correlation between all of what I just talked about with youth and the explosion in mental health issues. And actually, his argument is that the moment the iPhone came out with the camera that looks directly at you, that's when things just started to get exponentially worse. That said, we have it, and it's not going away. So I do think that there are places where it can be harnessed for good. I think that there do need to be limits set for it in youth, and it is, speaking from experience with my own kids, it's really hard because everybody else is doing it. Why am I not getting that same thing? And then you might make them feel disconnected. But I do think that, for instance, it's starting in different states, red and blue states, that they're saying that there's no phones allowed in school. I think that's a good place to start. I also, my dad gave me a typewriter when I went to college too. So.
Mine had self-correcting tape.
Yeah, exactly. There was that like white tape too. Yeah.
Anyone else have a question? Yes.
So, I particularly work in homelessness. I run a homeless shelter. And most people that I talk to about mental health, they're like, yeah, we need help with mental health with homeless people. But what are your thoughts in like what we can do to actually like research this a little better with like the role homeless shelters play in mental health? Because usually in this industry, we just pass that off to someone else and we say, go see this person. But our shelter, we're trying to like figure out like how can we create something? How can we gather the right data? And when we ask people what data should we be collecting, because I went to like a mental health thing in symposium in Bastrop County, and I asked the question, what data should we be collecting? And no one could tell us what we should be collecting. And so now we're trying to move forward, but we're really stumbling on in the dark. And so I'd like to know from you, what can be done? What are your thoughts on ideas of we should be moving in that direction?
Well, as I stated at the beginning, I'm not an expert public health researcher, but I'll tell you my thoughts. I guess my first question for you is, what is being offered besides the shelter, which is hugely, as we talked about with that big pie, hugely important? What are there mental health services being offered?
So usually they send them to like Bluebonnet Trails or some mental health facility, and then it's like they have to be able to get the health care and insurance in order to cover that. And so it's like, that's why I'm thinking, what can shelters do? What data can we collect to know what we can do in order to be able to figure out how the shelter can have a more direct role in mental health and creating the right environments for mental health, instead of just shipping them off to some therapist and then they come back to the shelter and the environment of the shelter hasn't changed or their personal environment hasn't changed. And so that's where I'm looking, is like, how can we make the shelter more mental health friendly instead of just pushing them off onto a therapist?
Well, my answer to that is ask the people. I think that you have to start there. I mean, instead of looking at the interventions, you meet them where they are. What do they want the most? What is going to be most helpful? What are they most frustrated that they are not getting when it comes to mental health? And start there. To actually, the stakeholders themselves, the people who are unhoused, how can they tell you what is going to be most important and needed, and then guide some sort of program based on that, which then you could look at the efficacy of it.
I can answer that a little bit too. I always talk about when you ask, what do I measure? Looking inward first to say, what do we do and what do we do well? Not only in terms of the quality, but the quantity. So when you have people that are coming back again and again, why are they coming back? So looking inward to really have data about the services that you provide and the role that you play for your community. So when you know yourself, then you look outward and you say, well, what's everyone else doing? And that data is available usually and you can collect it. But what that allows you to do is compare what you're doing, what everyone else is doing with the gap or the need. And that need becomes very clear when you take this sort of look across in terms of where you are and where everyone else is, to say, I see a gap here that maybe we can integrate into what we're doing. And then working with the people that you serve to make sure that that's what they need, like you said, to kind of double check and perception check, is this needed? Is this really a gap here? And then how do we deliver it so that you add to what you do?
Thank you. I wanted to add one other thing to that, is that in the world of homeless shelters, they operate independently. They're like, when we first started, we tried to get information from shelters around the country when we started the shelter, and no one would give us anything. And so going to other shelters and saying, what are you doing in the way of mental health? How are you they're not going to give us that data. They're not going to give us any information. And so on its face, what you said is great. Go to what has been done, what is other organizations doing. But when the data is unattainable, and my shelter is like, we need to make new ground, that's why I'm looking to mental health professionals and I'm saying, what should I be doing? How can I do better? Because my industry doesn't do anything other than go see a mental health professional.
So my translational health hat would say, you need to work with Texas State to identify the shelters and collect the data so that your story is being represented accurately in terms of what you do and what others do, so that you can begin the process. But that's where the community partnerships with academic institutions play a critical role, because we have people that do data and you have people who do services, and we need to be able to understand those services in a very evidence-based way. So that's why we like to work with people like you and in institutions like yours. So thank you for that.
I'm wondering if there's a regulatory agency that regulates the homeless shelters that already is collecting the data, but then just doesn't share it. I mean, so maybe you could get it from the regulatory agency.
So there is the point-in-time count for the United States, but those of us in this industry consider it to be fraud, and it does not represent the reality. And so it leaves shelters scrambling on their own.
I love the idea exchange and connection that's happening here with this showcase.
You didn't even know this, but while you were speaking,
oh no.
we had a graphic artist make the representation of the conversation, and I did not know that it was behind us. Did you?
No.
Well, there it is.
Wow.
There it is. So thank you very much. Wow, there's a lot to unpack there. But I think that you will agree that social connection is part of what we do at our center, part of what we do with our community members, and everything that you talked about really resonates with us. So let's continue this conversation. I think we will be able to have a little of food and beverages downstairs and continue the conversation. But I want to thank you.
You hit my mic again. I'm so overwhelmed. Thank you.
Anyway, I want to thank you very,
Well,
very much.
thank you
for
so
joining
much.
us And for giving us those important remarks about what's happening and how we're bridging the divide and what else we can do. That is job security for all of us, right? There's a lot of work to be done. So thank you very much.
Thank you. Thank you, everybody.